Dear colleagues, this presentation is prepared for clinical key for electrical stimulation in physiotherapy and rehabilitation project. The project partners are Pamukkale University, University of Craiova, Hatay Mustafa Kemal University, Başkent University, Süleyman Demirel University, Schley State University of Applied Science, Burdur Mehmet Akif Ersoy University, and National Physiotherapy Associations. I am Özlem Yürük from Başkent University. The subject is electrical stimulation for patients with scoliosis. Scoliosis is a complex three-dimensional deformity of the spine that comprises a lateral curvature in the frontal plane, thoracic lordosis in the sagittal plane, and posterior rib hump, which is produced by rotation of the vertebrae in the transverse plane. These results in posterior elevation of the rib cage on the convex side of the curve and a depression on the concave side. This alignment disorder of the spine was first described by Hippocrates. Galen used the scoliosis term for the curvature of the spine. Scoliosis can be classified according to etiology, localization, curve pattern, angle, functional and structural changes, and age. Scoliosis is usually seen in the thoracic or lumbar region. It is classified as C or S scoliosis according to its pattern. Scoliosis is divided into functional and structural types. Postural, compensatory, nerve root irritation, inflammatory, or hysterical problems may cause functional scoliosis. In functional scoliosis, changes in the spine are reversible. Structural scoliosis is irreversible lateral curvature and rotation of the spine. Structural scoliosis is classified as idiopathic, congenital, neuromuscular, traumatic, or tumor origin scoliosis. Most cases of scoliosis are idiopathic. According to age, it is divided into infantile, juvenile, and adolescent. The most common form of scoliosis is adolescent idiopathic scoliosis, which appears in late childhood or adolescence. Early diagnosis and treatment are essential for scoliosis. As the condition is most often painless, early diagnosis is difficult, especially in countries where school scoliosis screening is not implemented. External change to the body shape is minimal in the early stages, and most changes in back shape occur predominantly on the back of the trunk, which is difficult for parents to see and can be concealed by clothing. The consequences of scoliosis are altered spinal mechanics, loss of spinal mobility, pain, psychological problems, cardiac and respiratory dysfunction, loss of function, or disability. Various treatment methods have been used for the treatment of scoliosis since ancient times. Scoliosis management includes conservative treatment and surgical procedures. The treatment program should be individualized according to the patient assessment and the progression of the curvature. The main goals of the treatment are to correct the deformity, limit or stop the curvature progression, restore the trunk symmetry and balance, minimize pain, avoid cardiopulmonary complications, prevent the long-term consequences of the deformity. The clinician decides the treatment approach by considering the progression, localization, and pattern of scoliosis. The individual's cosmetic appearance and social factors should also be considered during the decision-making process. Patients with a curvature below 20 degrees are reassessed at 6 to 11 months intervals. Conservative treatments are prescribed above 20 degrees of curvature. If the curvature is above 40 degrees, the surgery is recommended. Conservative management includes scoliosis-specific exercises, bracing, manual therapy, and neuromuscular electrical stimulation. The evidence of these treatments are unclear. Scoliosis is a three-dimensional deformity, so the treatment should also be considered in the three dimensions. Shirok, Lyon, scientific exercise approach to scoliosis, side shift, Barcelona School of Scoliosis, and functional individual therapy of scoliosis are the most known treatment approaches. A spinal brace may slow the progression rate of the curve, but also cause skin irritation, rashes, and decrease physical activity. It also adversely affects self-concepts and body image. Neuromuscular electrical stimulation is a traditional method that's used in the treatment of scoliosis. In this, now, patient evaluation. Before the clinical decision-making for physiotherapy and rehabilitation program and electrical stimulation, a detailed patient assessment is essential. Posture, range of motion, muscle strength, flexibility, pain, and respiratory function should be assessed in patients with scoliosis. Scoliosis-specific evaluations should also be performed with standard physiotherapy and rehabilitation assessment. Radiological evaluation, Adams test, Tanner and Risser sign, and scoliometer can be used. The aim of the neuromuscular electrical stimulation in patients with scoliosis are to limit or stop the curvature progression, strengthen paraspinal muscles, maintain a balance between muscle groups, restore trunk symmetry and balance. Patients with 20 to 29 degrees curves show a progression or curves of 30 and 39 at the beginning. And skeletally immature individuals are suitable for electrical stimulation. Neuromuscular electrical stimulation is not used for curvatures above 40 degrees. In the studies, neuromuscular electrical stimulation was used alone for at least 8 hours at night in the long term. Curtin and Lowry used a biomechanical modeling and computational optimization to investigate muscle activation in combination with applied external forces as a treatment of scoliosis. The results indicated that superficial muscle activation on the convex side of the curve provides the best corrective results, supporting previous in vivo stimulation studies for neuromuscular electrical stimulation. Grimbley et al. Applied 30 Hz frequency long-term electrical stimulation at the posterior axillary line on the convex side of the curvature to correct the spinal deformity. The patients were followed up with muscle biopsies taken from the latissimus dorsi muscle of the stimulated side before electrical stimulation and after the 3 and 6 months of application. There was a tendency for increasing percentage of type 1 and especially type 2C fibers after stimulation. The mean muscle fiber area and fiber areas of the various fiber types didn't change significantly. Histopathological findings were generally rare before as well as after 3 months of electrical stimulation. The only noticeable finding being a somewhat increased frequency of atrophic fibers in the groups after 6 months of stimulation. In all patients, the enzymatic activity of citrate synthase increased after 3 months and further in 3 patients after 6 months of electrical stimulation. This study provided some evidence of an adaptive process caused by electrical stimulation toward a more fatigue-resistant muscle. In early studies, it was shown that electrical stimulation was effective on scoliosis. However, these studies include immature and a small number of mature patients still under treatment. Recent studies show that electrical stimulation was ineffective in slowing the rate of progression or decreasing the curve. It has been concluded that the effect of electrical stimulation is consistent with the natural progression of the disease. Neuromuscular electrical stimulation used for a long duration in early studies. Kowalski et al. Investigated the effects of long-term electrical stimulation in an animal model. The authors applied electrical stimulation to rabbit supraspinal muscles at 9 hours per day for 3 months. In comparison to the control animals, the muscles of overstimulated rabbits exhibited clear signs of microscopical lesions, including the depletion of the myofilaments, proliferation, dilatation, swelling of the sarcoplasmic reticulum, mitochondria, as well as the signs of destruction of the Z-line. The degenerative processes associated with the Z-line and the observed microlesions strongly suggest that the failure of the long-term electrical stimulation therapy of scoliosis may be attributable to the ultrastructural lesions. In recent years, studies showing the effect of short-term 1-hour electrical stimulation combined with other conservative methods have been published. And neuromuscular electrical stimulation protocol for scoliosis. Electrical stimulation parameters are varied in the literature. However, a general outline of the electrical stimulation protocol is shared. After the initial assessment, the family and the patient should be informed about the purpose and process of the treatment. Introducing the electrode and stimulator before administration may increase the patient's compliance. The stimulator could be given to the parents for home use. The therapists should re-evaluate the patients subsequently 3 to 4 months intervals. And the electrical stimulation parameters. Electrical stimulation parameters could be arranged with a dual channel unit that delivers strains of a rectangular alternating current pulses with a stimulation duration of 150 to 400 microseconds, a frequency of 25 to 100 hertz, and 3 to 3, 6 to 6, or 5 to 25 on-off period. The amplitude of the stimulus is slowly increased until the acceptable level. It is recommended to have a variable amount of visible contraction and to be increased up the patient's maximum tolerance. The duration of the sessions is 1 hour in the recent literature or about 8 hours at night in the past literature. The total treatment duration varied between the patients. The treatment duration is between 3 months to 2 years. Electrical stimulation can be used paravertebrally with both electrodes on the convexity of the curve. If the curve is in S pattern, 4 electrodes can be used. The electrodes are placed symmetrically to the apex of the curve by avoiding stimulation toward the concavity of the compensatory curves and undesirable stimulation of the shoulder girdle. The distance between the electrodes depends on the curve and trunk size. The electrodes must remain within the boundaries of curvature. Electrical stimulation can reduce femur and compensatory spinal curvature in the frontal and sagittal planes. Electrode placement over the lateral trunk muscles rather than on the paraspinal muscles can cause progression of scoliosis. This is called lateral electrical surface stimulation. The amount of the curvature is determined by the length of the skeletal level arms. The electrodes can be placed in the lateral trunk muscles for scoliosis, paravertebral muscles for kyphosis, and rectus abdominis muscle for lordosis. The physiotherapist should explain and show landmarks to parents for electrode placement for home use. Because the treatment duration is so long, skin irritation can be seen in application. If these side effects occur, the physiotherapist gives break to the treatment. Most studies investigating the effect of electrical stimulation in the treatment of scoliosis have been conducted in past years. The number of recent studies is very few. In a Cochrane review, the authors identified no evidence examining the effectiveness of surgical interventions compared with non-surgical interventions for people with idiopathic scoliosis. As a result, they could not draw any conclusions regarding the benefits or harms of these treatments. In past studies, these studies found that electrical stimulation had positive effects of progression of the curve. But in these studies, electrical stimulation was used as a single treatment method for patients. In a study conducted by Scoliosis Research Society, 159 girls with a mean age of 13 years who had adolescent scoliosis were followed prospectively until skeletal maturity or until the curve had increased to 60 degrees or more. All patients had an initial curve of 25 degrees to 35 degrees, and the apical level between the 8th thoracic and the 1st lumbal vertebrae. Of the 159 patients, 120 were observed without treatment, and the 32 were management lateral electrical surface stimulation. The curve progressed at least to 60 and 80 patients. There was no obvious difference in outcome between the patients who managed with observation or electrical stimulation. And in recent studies found that if electrical stimulation combined with exercise or brace, it may be more effective. Scoliosis is a complicated problem for children with cerebral palsy. In cerebral palsy, they do not have many treatment options, and scoliosis is usually refractory. In a recent study by Coe et al., evaluated the effects of lateral electrical surface stimulation on scoliosis and trunk balance in children with cerebral palsy. Electrical stimulation has applied 2 sessions per day. And they found that lateral electrical surface stimulation may be an option for managing stationary or progressive scoliosis in children with cerebral palsy. Maruyama et al. Found that bracing is more effective than electrical stimulation in preventing the progression of the curve in patients with adolescent idiopathic scoliosis. And Fisher et al. Compared 3 years results of electrical stimulation with the Milwake brace for the treatment of idiopathic scoliosis. 50 patients in each group were compared retrospectively and matched for age, sex, research sign, and curve morphology. Evaluations were performed at 6-month intervals with radiographs and examinations. No significant differences were found in the rates of curve progression or failure. And they said that electrical stimulation might be comparable to the Milwake brace in managing idiopathic scoliosis. And in conclusion, we can say that neuromuscular electrical stimulation can be used in progressive idiopathic curves of 20 to 39 degrees. Although beneficial effects were reported for electrical stimulation in primary studies, the clinical evidence of electrical stimulation in scoliosis is still inconclusive. In past studies, electrical stimulation was used for a long time, and it seems impractical. In the light of current knowledge, it may be possible to use it combined with other conservative treatments methods for a short period. Further studies should be planned on scoliosis to determine the effects of electrical stimulation. Thank you for your attention.